Welcome to PharmaconHealth. Have you ever wondered why some medicines are considered safe while others require constant blood tests and extremely tight dose control? The answer lies in one of the most fundamental concepts in clinical pharmacology, the therapeutic index. It is literally a number that measures how dangerous a drug can be. Stay with us. By the end of this video, this concept will be permanently locked into your clinical thinking. By the end of this video, you will clearly understand what the therapeutic index is and how it is calculated, the critical difference between the therapeutic index and the therapeutic window, which drugs carry the highest clinical risk and why, and how healthcare providers use therapeutic drug monitoring to keep patients safe. Let us begin. Let us start with the definition and a simple analogy that will make this concept instantly clear. The therapeutic index, abbreviated TI, is a pharmacological ratio that compares the dose of a drug that causes toxicity to the dose that produces the desired therapeutic effect. The formula is straightforward. T equals TD50 divided by ED50. TD50 is the dose that causes a toxic effect in 50% of a test population. ED50 is the dose that achieves the intended therapeutic effect in 50% of that same population. A higher T number means a larger margin of safety. A lower T number signals danger. Here is a concrete pharmacology example. Penicillin G has an ED50 of approximately 0.01 milligrams per kilogram for most bacterial infections, while its toxic dose in humans is many thousands of times higher, giving it a very high T. A significant dosing error with penicillin is unlikely to cause life-threatening harm. Now contrast this with digoxin. The therapeutic blood level is just 0.5 to 10 nanograms per milliliter, and toxicity begins the moment levels exceed 10 nanograms per milliliter. That is an extraordinarily narrow margin of safety. Now that we understand the formula, let us explore what high versus low T truly means for patient safety, using a memorable analogy. Think of a high T drug as a wide, multi-lane highway. Even if you drift slightly out of your lane, you have plenty of room before danger. A low T drug, by contrast, is like walking a tightrope across a canyon. Every millimeter matters. One small misstep, a missed dose, a drug interaction, impaired kidney function, can mean the difference between the drug working therapeutically and it triggering a life-threatening reaction. Clinically verified examples of high therapeutic index drugs include penicillin-class antibiotics, most antacids, and acetaminophen, known as paracetamol, at therapeutic doses. However, acetaminophen carries an important teaching point every clinician must understand. Despite its high T at normal doses, in overdose it generates a toxic metabolite called an APQI. An APQI depletes hepatic glutathione stores and causes fulminant hepatotoxicity. This teaches us that T is always dose context dependent. Now, the single most important mnemonic in clinical pharmacology for low T drugs, DLW. Dangerous little window. D is for digoxin. Therapeutic blood level, 0.5 to 10 nanograms per milliliter. Toxicity causes ventricular arrhythmias, bradycardia, and visual disturbances, classically described as seeing yellow-green halos around lights. L is for lithium. Therapeutic serum level, 0.6 to 1.2 millimoles per liter. Early toxicity, fine tremors and polyuria. Severe toxicity, above 2 millimoles per liter, can cause seizures and cardiac arrest. W is for warfarin, target INR, 2 to 3. Below 2, thrombosis risk. Above 3, serious hemorrhage risk. All three require mandatory therapeutic drug monitoring. Now let us move from the T ratio to an equally critical clinical concept, the therapeutic window, which is what we actually measure in living patients. Here is a distinction that confuses many students and even some clinicians. The therapeutic index is a laboratory ratio, a number derived from population-level dose-response studies. The therapeutic window is the real-world, patient-specific blood concentration range where a drug is simultaneously effective and safe. Think of T as the theoretical ruler, and the therapeutic window is how we applied that ruler in the clinical setting for an individual patient. The textbook example of a narrow therapeutic window is phenytoin, a first-generation anti-epileptic drug. Its therapeutic window is 10 to 20 micrograms per milliliter in plasma. Below 10 micrograms per milliliter, seizures are not adequately controlled. At 20, nystagmus begins. At 30, ataxia and confusion. Above 40, cardiac arrhythmias and hypotension, potentially life-threatening. This concentration-dependent toxicity profile is precisely why phenytoin demands therapeutic drug monitoring, and why empirical dosing without blood level checks is considered poor clinical practice. The therapeutic window does not remain constant. Patient-specific factors can shift it dramatically. Let us examine the 5 most important variables. 5 patient-specific factors critically alter drug safety and the effective therapeutic window. First, renal function. Most drugs and active metabolites are cleared through the kidneys. In a patient with chronic kidney disease, digoxin can accumulate to toxic levels if the dose is not adjusted, because about 70% of digoxin is eliminated by the kidneys. Second, hepatic function. Warfarin is metabolized in the liver by the enzyme CYP-C9 in patients with cirrhosis. This metabolism is significantly reduced, increasing the risk of serious bleeding. Third, age. Elderly patients often have reduced renal and hepatic clearance, lower total body water, and altered plasma protein binding, all of which can change drug distribution and increase sensitivity to medications. Fourth, drug-drug interactions. Amiodarone inhibits CYP-C9, the same enzyme responsible for metabolizing warfarin. This interaction can raise INR2 dangerous levels and greatly increase bleeding risk. Fifth, pharmacogenomics. Patients who are CYP-D6 poor metabolizers convert codeine to morphine unpredictably, which can lead to opioid toxicity even at standard doses. Given these real patient risks, what do healthcare providers actually do to protect patients? This is where therapeutic drug monitoring becomes indispensable. Therapeutic drug monitoring, TDM, is the clinical discipline of measuring drug concentrations in blood at defined time points to ensure they remain within the therapeutic window. TDM is not simply checking a blood level. Timing of the sample is critical. Trough levels, drawn immediately before the next scheduled dose, reflect the drug's minimum concentration. Peak levels, drawn 1 to 2 hours after dosing, reflect maximum concentration. For aminoglycosides like gentamicin, both peak and trough matter. The peak drives bactericidal efficacy, while an elevated trough predicts nephrotoxicity. For lithium, the standard is a trough level drawn exactly 12 hours after the last dose. Each drug has its own validated sampling protocol. Patient education is not supplementary to therapy, it is therapy. And for narrow T drugs, it is life-saving. Patients on warfarin must understand that vitamin K-rich foods, spinach, kale, broccoli, reduce warfarin's anticoagulant effect, potentially causing dangerous blood clots. Food is a pharmacological variable. Patients on lithium must know that dehydration, from vomiting, diarrhea, fever, or excessive sweating, concentrates lithium in the blood and can rapidly precipitate toxicity. Salt restriction has the same effect through renal lithium retention. Patients on digoxin must immediately report nausea, vomiting, loss of appetite, or, most classically, seeing yellow or green halos around lights. These are early warning signs that, if acted upon quickly, can prevent fatal arrhythmias. Let us now bring everything together with a final clinical summary. Here is your definitive clinical summary. The therapeutic index equals TD50 divided by ED50. A higher number means wider safety margin. DLW digoxin, lithium, warfarin are the 3 most clinically critical narrow T drugs, all requiring mandatory TDM. The therapeutic window is the patient-specific blood concentration range where drugs are simultaneously effective and non-toxic. 5 patient factors: renal function, hepatic function, age, drug-drug interactions, and pharmacogenomics, can shift this window significantly. Patient education about food interactions, dehydration, and early toxicity symptoms is as clinically important as the prescription itself. If this video added to your clinical or pharmacological knowledge, please subscribe to PharmaconHealth and share it with your colleagues, students, and medical teams. Next week, we go deeper into drug-drug interactions with real case studies on CYP enzyme inhibition and induction. Thank you for learning with PharmaconHealth, where pharmacology protects lives.